Good afternoon, everyone. My name is Kate Shamszad. I'm the Director of Policy at the New Jersey Healthcare Quality Institute, and I'm very glad to be here on what feels like a momentous occasion to discuss the proposed integrated facility licensing regulations for the state of New Jersey. So thank you all so much for being here today. We are hoping to have a robust opportunity for overview of these regulations and discussion together. And we know that you all have been very much working on a on integrated licensing for many, many years. And this feels really like a culmination of decades of work that we've all been doing together. So glad to have everyone here today together. Particularly glad to be able to introduce my co-facilitator, John Jacobi, who works as the Dorothea Dix Professor of Health Law and Policy at Seton Hall Law School, an advocate for integrated care for many, many years. And alongside him, Linda Schwimmer, President and CEO of the New Jersey Healthcare Quality Institute, will also help facilitate conversation and discussion today. Isa, can you move it to the next slide, please? Just by way of our agenda for this afternoon, just some quick housekeeping. We've got Vanessa from the Quality Institute who is monitoring the chat, and she'll be putting helpful information to guide us all together today there, and keeping a close eye in case anyone needs anything. Additionally, we'll have opening remarks delivered by our Acting Commissioner of the Department of Health, Jeffrey Brown, and then we'll move into an analysis and discussion of the regulations, highlighting key points, though not every single page of the 244-page document will be reviewed. We will be going over a number of key components. And then finally, we will spend the majority of our time together in discussion, both understanding from your perspective, any questions or comments that you have about the regulations, and being able to put together guidance back to the Department of Health as requested. We'll then close, giving you all the opportunity to get on with your busy days. So without further ado, next slide, please, Isa. I'm happy to introduce Jeffrey Brown, who is our Acting Commissioner of the New Jersey Department of Health. A Mercer County native and summa cum laude graduate of Rutgers University, Brown has led major health initiatives across the state. He's previously served as the Deputy Commissioner overseeing regulation of healthcare and behavioral health facilities, as well as major funding programs like charity care and graduate medical education. He was also the first executive director of the New Jersey Cannabis Regulatory Commission, where he expanded access to medicinal marijuana and developed the regulatory framework for New Jersey's recreational cannabis industry. So I'm going to turn things over to him. Isa, you can take down the slides for a moment so we can give him the floor.
Good morning, everyone, and thank you, Kate, for the introduction. Greatly appreciated, and very happy to be here to talk about this. What we view as really it is the culmination of years and years of work. I know lots of you as stakeholders, as experts in this space, have worked hand in hand with the department, providing feedback, providing information on barriers related to integrated licensing. And so, we appreciate everything that you've all done over the years to get us to the point where we are today. I'm going to provide just an overview of the new rule we're proposing, just very briefly, and talk a little bit about the current state, so how our licensing system works now, and then the future state, how we envision it working after this rule is adopted. It's in the public comment period, so we encourage everybody to look at the rule and submit public comments. We want to hear from you. We want to respond to questions, comments, clear up what we can through that process. So just broadly, for years, and there was a statute passed, I believe it was in 2017, if I'm not mistaken, it might have been 2018, basically calling for an integrated license. And that between, at the time, it was, Department of Health to develop, but also in consultation with the Department of Human Services. In that interim, we've had Division of Mental Health and Addiction Services move to the Department of Health, move back to Department of Human Services. We've retained some of the licensing licensing capabilities here. But before I get to the overview, I wanted to start by thanking a couple people. So first and foremost, former Commissioner Dr. Caitlin Baston. We would not have gotten this over the finish line if it weren't for her work. and her dedication to getting this done. When I came on as deputy commissioner, we met for coffee first, and she said that her number one priority was to get the integrated licensing rule done. And so, really a credit to her. And she lived integrated care before she became commissioner, and was really an expert and brought that expertise to the table as we developed these rules. And I kid you not, literally sitting for days and hours with our regulatory officers to get the rule done and into a place where it is now. Also want to thank Commissioner Sarah Edelman, the Department of Human Services, and Deputy Commissioner Val Milkey there. Without their partnership and without their help, we also would not be where we are today, because it's really, this is particularly when we're talking about mental health and substance use treatment. We license the facilities, they have the program standards, and really handle that aspect. So it's really a partnership between the two departments that got us to where we are. So broadly speaking, integrated care, which we're proposing in this new 843K, integrated licensing, would enable an entity that wants to integrate different types of services, particularly primary care, reproductive health, mental health, substance use treatment, and some adjunctive services, to provide that all under one roof in a truly integrated fashion. So, over the years, the department has issued waivers and such, but, really what we're trying to prevent is, facilities having to comply with different sets of standards, for different parts of their business if they want to truly deliver integrated care. So to let you know a little bit about the current state, right now, primary care, family practice, family planning, reproductive health is covered under 843A, which is our ambulatory care facility licensure rules under the Department of Health. Mental health licensure rules are under 8121, and then substance use treatment disorder rules are under 10161B. And although that's in Department of Human Services chapter, when the reorganization happened and some of these transfers happened, the authority to enforce those rules came over to the Department of Health. So what we're doing with the new proposed 843K, is taking those three sets of rules, which, sometimes there were conflicting pieces of them, they didn't always align, and putting them into one chapter for a new integrated license. The way the proposed chapter works is that you have licensure procedures, operational standards, for us enforcement authorities that are consistent across all facilities licensed under the integrated rule chapter. And then there are standards for each different license type that would fall under the integrated license. So, those would be subchapter 6 is behavioral health services. Subchapter 7 is healthcare services. And then we also cover opioid treatment programs and some other types of services here. Under behavioral health services, that includes not only outpatient mental health, but outpatient substance use treatment. Same with intensive outpatient and partial care programs. When we're talking about healthcare services, that includes primary care, prenatal and postpartum care, pediatric care, as well as some medical specialty services. So, we have the rules that apply to everybody, specialized rules for behavioral health services, specialized rules for healthcare services. But we also have a section, adjunctive services, which are services that can be provided by any facility licensed under this chapter, provided that they're approved to do so by the department. So you could view adjunctive services as services that they don't necessarily require a whole new license, but there are standards related to them for facilities, entities that want to provide those services. So some examples of those are preventative medicine. So i.e., for a substance use treatment provider or a mental health treatment provider that wants to provide some preventative medicine services, but doesn't want a full primary care license, the adjunctive service will enable that to happen. Wound care is an example, thinking about substance use treatment facilities. Obviously, their clients, especially if they're using substances intravenously, could require wound care services. So this chapter will enable facilities that provide substance use services to potentially provide wound care services without having a full healthcare service license. And there are other adjunctive services. I'll note harm reduction is another one as well. There's a whole subchapter on storage, administration, and dispensing of medication and administration of controlled dangerous substances for treatment of substance use, ambulatory withdrawal management, and or stabilization. So that's things like MAT, basically, different forms of medication that can help people dealing with opioid use disorder or other substance use disorders. So, that's the rule structure. As we note in the intro, things like separate doorways, separate spaces, we're trying to get rid of that, trying to allow for true sharing of space and sharing of services. And same thing with medical records. I think before facilities who were licensed under different chapters had to have separate medical records. Here, facilities can have one medical record. The one caveat to that is that psychotherapy notes and some other things required by HIPAA will have to be separate from that medical record, but that's pursuant to federal law. And so, that will continue, but otherwise these facilities can have an integrated medical record. Also, there's flexibility here for alternate care locations. So facilities licensed under this chapter can provide services on an intermittent basis off-site. They can have mobile vans, which I know, particularly when we're talking about, I think, opioid treatment programs and some other providers, they already make use of those. And really the goal with alternate care locations is to provide some flexibility between providers. So, again, if you say you're a substance use treatment provider, want to partner with another provider to provide primary care services, there's a mechanism to do that. Of course, facilities can also fully integrate and provide everything under one roof in one facility. So that's really an overview. It has been a long road to get here. I know Professor Jacobi is going to walk everybody through the rule and collect questions and analysis. And thank you to Linda, who's offered to put some of that together to get to us. We'll try to clarify some things, but most importantly, public comment period is open. And so, really that's the formal way to submit comments on the rules. We encourage you all to do that. We want to hear from you. We want to understand what ambiguities you might see in the language that we may need to clear up in responses. But overall, we're just really excited to be at this stage. And our goal is to adopt these during this administration. Obviously, the clock is ticking on that, but we want to adopt these and get to implementation so that facilities can start operating under this new integrated license framework. So I'll give one more thanks to Linda and the team at the Quality Institute. It's great to be here. Thank you for hosting, and thank you all for joining.
Thank you so much, Acting Commissioner. We are glad to see you spearheading these efforts, and thank you for joining us. We know that you're planning on dropping off, and we will get right to work in our review and collection of feedback. So thank you so much.
Thank you so much. Have a great day, everyone.
Thanks. All right, just by way of what is happening next, I'm going to turn things over to John Jacobi to get us started. We have about 10 slides that we're going to get through before we start moving into comments. So if you've got comments and questions and thoughts as we are going through these slides, please feel free to drop them in the chat. Make use of the Google form if you'd like to put things there and you have some thoughts you'd like to lead. And then after we get through our slides, Linda will be leading us in some facilitated discussion. So that's our next steps. John, I'll turn things over to you.
Thanks, Kate. And Kate and I will share walking through these slides. I want to make sure that people understand that we are not going to go through the entire regulation. We are going to hit some of the issues that we think are overarching issues and some issues that we think might be of concern. And I will say at the outset, and I will say again, that in this kind of setting, we always benefit from hearing from people who are actually providing the services, whether they're practitioners or managers. before we provide comments. So if we get something wrong, tell us. If you think we missed something that's really important, tell us. So I want to start by just doing a little bit of history. I've scanned the attendee list, and many of you have been on this road for more years than I have, and I've worked with many of you on the efforts to get integrated care in the regulations in New Jersey. And I just wanted to say a couple things about the reason that this is so important. I think that I am preaching to the choir here, but the problem of the fragmented standards in New Jersey included the problem that if people were patients were unable to get all their care under one roof, there were a couple of categories of concerns for patients. For people who had both physical and behavioral health concerns, and they were getting their care from a physical health provider, the behavioral health services and needs were often undiagnosed. If they were diagnosed, they were sent a referral to go someplace else, which sometimes was they were unable to meet that referral, so they were lost to care. And for people who were receiving their services primarily through a behavioral health provider, but not well connected to primary physical health, as we all know, they suffered decades of lost life not because of their mental health issues, but because of their physical health issues. So this regulatory process has been important to all of us. And while this integrated care regulation is important, it really reflects what all of you have, or most of you have said to me over the years, which is if there aren't warm handoffs, if there isn't team care, if there isn't oversight of all the care of a patient, then you're not really addressing the needs of patients. And the bottom line here is that this is a big step forward. The regulation essentially does what it says it's going to do, what Acting Commissioner Brown said it was going to do, which is to allow for the provision of the modalities of outpatient care together under one roof, which is a huge step forward. I know that there have been waivers and accommodations over the years, but the regulations needed to be changed, and now they will be. Next slide. So let me just describe a little bit of the background, and then hand it off to Kate for the next couple of slides. So the structure of this regulation is to create, as Acting Commissioner Brown indicated, a new chapter in Title 8, 43K, which will house this integrated license, the integrated license structure, the process, the application process, and so on. It has in it a social. The regulatory proposal has a social impact statement that says what we should, not to put too fine a point on it, hold the department to, which is that patients will benefit from the ability to access all these services together. And if the department's falling short in its promise to do this, we should make sure that they know that. It will undoubtedly reduce stigma and reduce unnecessary separation of services. And it is intended to, and it should, improve caregivers' efficiency by reducing administrative, regulatory, compliance, record keeping, and other bureaucratic burdens. So the top line takeaway here is that this regulation is structured essentially with a drop-down menu, which means that you can, within this one regulatory structure, you can select which modality of care you wish to pursue, one, two, or all of the modalities of care that are included in this regulation, and within the same framework, apply for approval for that licensure structure. We'll talk a bit in a moment about the transition, how you get from here to there. The caveat that Commissioner Brown described is that some of the behavioral health services are still subject to programmatic oversight from the Department of Human Services. That has been the case, and it will continue to be the case. That is sort of incorporated in the structure of this regulation. We'll see how that works. The important things from my perspective, as someone who has approached this as a lawyer and as a board member in nonprofit organizations, is that the ability to rationalize leadership, the governance body, the executive leadership, the clinical leadership within one team, within one structure, is going to be an important step forward. I think most organizations that provide these kinds of services have figured workarounds to be able to do that. Now it will be very much more straightforward. Now, I'll have a few things to say about mobile and remote services, which are covered in this subchapter, but I'll get to that in a bit. And I'll repeat that I'm not a clinician, and I don't provide these services. I'm the board of organizations that provide these services. But we need to hear from you as you're listening to us and as you're reviewing these regulations to make sure that we are making comments that are sensible and responsive to your needs. The comments are due on June 20th. So we'd like to hear from you sooner rather than later on these things. And I'm going to turn it over to Kate for the next slide.
Thanks, John. Great. So as we've shared, this is a very comprehensive rule that's been introduced. This slide gives you a sense of the full structure of the proposed rule, which is organized into 12 subchapters under the new 843K. As you can see, it's a comprehensive framework. It touches pretty much on everything from general provisions and licensure procedures to detailed operational standards, patient care policies, and clinical services, inclusive of behavioral health, reproductive health, and opioid treatment programs. There are also specific sections on adjunctive services, as was described by Acting Commissioner, like wound care and harm reduction, as well as requirements for medication storage, controlled substances for SUD treatment, and the mobile and alternative sites, as John just described. Given that we don't have many hours, we won't be walking through every subchapter in detail today. Instead, we'll focus on key highlights, which I'll describe in a moment. But we do encourage you to take the time to read the full rule text. Again, especially echoing what John said, we are not clinicians. We don't live and breathe this work every day. And so it's essential that you, who will be taking on this integrative licensure process for your sites, are able to share feedback on all sections in addition to the ones we're highlighting today. Next slide, please. So these are the key areas that John and I will be describing as we review the proposed rule today, starting with the transitional licensing process. Many of you already hold multiple licenses for different service lines, and so we want to talk about what that transitional process looks like. We'll also be talking about staffing and administrative role requirements because these have been streamlined significantly within the proposed rule, and then we'll be reviewing some definitions as they relate to behavioral health. We'll also be talking about new standards for harm reduction services, as well as requirements for opioid withdrawal management, including staffing, and supervision and document protocols. And then we'll talk specifically about reporting requirements for mobile and alternative care sites, as well as the continued oversight between DOH and DHS that will need to be coordinated as things go forward. For each of these sections, we are going to highlight what the rule changes, and then after we cover all of the sections, we'll have an opportunity for discussion and dialogue about what we've presented and about the proposed rule in full, with the intent that we will share our communal feedback with the New Jersey Department of Health on behalf of everyone who's attending here today, making it easier for you to submit your comments through us. As we go through each section, again, feel free to jot down notes, drop them in the chat, or share them on the shared Google Drive. We won't be taking any questions as we go through the next 8 slides, but we'll have plenty of time to keep talking. So John, I'll turn it back to you to talk about our first subject, transitional licensure. Next slide. There you go.
Okay, thanks, Kate. So how do we get from here to there? The regulations describe the process for people who currently hold licenses, one or more licenses, to get to an integrated license from where you are now. A facility that's currently licensed for one or more modalities can continue to operate under that license so long as it's in compliance with that license. After these regulations are finalized, which I'm not sure I want to hold them to it, but Acting Commissioner Brown said that they will be completed by the end of the calendar year. That means that they will receive comments, respond to the comments, and have the final regulations published. When that happens, within 60 days of the final publication of the regulations, licensees should have to submit a notice of an intention to renew pursuant to Section 43K, pursuant to the new regulation. So you have a license to provide ambulatory care services, and you have an existing license. And when these regulations are completed, you file a notice with the Department of Health saying, I intend to renew. I intend to renew under the ambulatory license section 43K, which will be the relevant license going forward. And you have to do that within 60 days of the final regulation, which is almost certainly going to be closer to Christmas than it is to Thanksgiving. The commissioner, the Department of Health will then issue a certificate of transitional licensure, which will be valid until the time of your scheduled renewal of your current license. So it will be a gap filler. You'll be operating under your current license with a certificate of transitional licensure. When your new license renewal is due, you will be licensed under Section 43K. One concern that we had was that we were hoping that the integrated care license would normalize the renewal and the inspection schedules for entities that are providing more than one service. The regulations do not say that that's the case. We asked Acting Commissioner Brown, before we allowed you into our little party. And we asked him, what about the normalization of inspection processes? And he says, well, you're right that the regulation doesn't describe that, but we have been working within the department so that we intend that the inspections will be together. So that if you have a mental health license and an ambulatory care license, the plan is to have one licensing team come to your facility to review for both of those licenses or all of your licenses. Now that was a commitment that he made, and I think that he was serious that they have been working on that at the department. They're aware of that issue. I asked him about the renewal issues, and that is a bigger problem because some of the renewal timeframes are different. The amount of time that you have under some licenses is different one to the next. So that's something to follow up on. That's something to see how we're going to deal with that transition. But again, the transition will be relatively simple. You file a notice within 60 days of the finality of this regulation when it's finally published. And then when your next renewal comes up, you will apply. They will provide the forms. The forms will be provided in the regulations, and you will then be licensed under 43K instead of your current licensure status. So it should be relatively seamless, he said, hopefully. Okay, now to you, Kate.
Great. Thanks, John. Another part of streamlining, next slide, Isa. A goal of streamlining, similar to what John was saying, and the hopes is that this will make it easier from a licensure process and an inspection process, is also the leadership and staffing that's required under this proposed rule and regulation. There isn't a particular section that I'm referring to here because there are different components throughout 843K that do speak to the required staff. But we just wanted to outline the leadership requirements that will apply under the new integrated licensing framework. These roles are critical to maintaining the clinical oversight, operational consistency, and quality assurance of all of the types of programs that will be integrated, especially in settings that are offering multiple types of care. First, in any facility offering primary care, reproductive health, preventative medicine, or administration of controlled substances for SUD, there must be a medical director, and this person is a licensed physician who can be employed or retained with a written agreement, either on a full or part-time basis. The exception to this is that if there is not primary care being offered, but the facility is exclusively providing behavioral health services in addition to SUD care, the medical director may be a psychiatrist. Facilities that are providing behavioral health services also are required to have a program director and a clinical supervisor providing direct clinical oversight to care staff. And this person must be a licensed and credentialed provider of behavioral health care, inclusive of an advanced practice nurse, licensed clinical social worker, licensed professional counselor, LMFT, psychologist, physician, or psychiatrist. Again, an exception to the rule if the facility is only providing SUD services and not behavioral health services, a licensed clinical alcohol and drug counselor may also serve in this role. There are some additional staffing requirements that are called out as being included in other department regulations. For example, pediatric staffing ratios for behavioral health is under regulations provided by DCF. And if those regulations remain, they're called out specifically within this proposed rule, and you can note them there. The intent of this leadership structure and the roles under an integrated setting is that there isn't duplicative roles anymore. So you are not required to have a medical director over each standing modality, but instead can have shared leadership, requiring a streamlined staffing process. That shows true in reproductive health. Next slide, Isa. Because reproductive health care services are part of the integrative license area of modality, there are some changes to the requirements for medical director. And in previous rules, the medical director needed to be someone trained in gynecology, and this rule allows for the medical director or staff physician to be someone who is trained in gynecology, including procedural abortion care. This can be a staff physician who has background either as a family physician, an obstetrician gynecologist, or someone who has a primary specialty in internal medicine or emergency medicine and has then gone on to have fellowship training or certification in family planning. This gives facilities some flexibility in staffing, acknowledging that qualified physicians may come from a variety of specialties, but have expertise in reproductive health care to be able to fulfill the role required for reproductive health to be included in the integrated license. John, I'll turn it back to you.
Okay, thanks. So this slide, I will admit, is one that I'm asking for help on. I assume that this is a cross-reference, but the definition of severe mental illness includes a legal threshold, the legal threshold for involuntary commitment. Now, I assume that this is a reference to intensive outpatient treatment, but I want to make sure that we're not missing something here. That this language, which is not otherwise used in Section 43K, but is defined in Section 43K, is not referring to something of which we should be aware and we should be commenting on. So I'm just throwing that out as a question for you to help us with. Next slide. So these are adjunctive services. So both Acting Commissioner Brown and Kate referenced adjunctive services, what as Acting Commissioner Brown described, the adjunctive services, which are in Title IX, or subchapter 9, refer to services that can be provided by a licensee without the application for a separate license. So as he described, for example, if you're providing substance use services, and wound care services are a natural pairing with that for people who are injection drug users, you're allowed to provide those services without getting an ambulatory care license, for example. Now, let me just say a couple of things about that. One is that in order to provide these adjunctive services, including wound care services, the provision has to be supervised by a licensed provider. And there are other requirements. You have to maintain clinical protocols and so on. One of the concerns that I will say that I have is that wound care services are often provided for IDU patients, and sometimes the organizations that are providing services, outreach and harm reduction services for people who are injection drug users, provide wound care in what could be charitably described as relatively informal settings by necessity, because they're dealing with hard to reach people and people who are sometimes unhoused. And we want to think about how the department is regulating things like wound care to make sure that they're not closing off this very important service for very vulnerable patients by overregulating it. Now, I'm not saying that it is. I think that it is appropriate to have sound infection control procedures for when you're doing wound care. But I do think I ask those of you who do this form of treatment to think about it, to look at the draft regulations and let us know what you think about that form of care. Now, in a related vein, there is a description of harm reduction services as another adjunctive services. And so again, these are services that can be provided by someone that holds one of the licenses without applying for a separate license. Um, what it does not address, this is not intended to address, is organizations that are currently registered under New Jersey statutory law as a harm reduction center. And so if you're registered as a harm reduction center, you continue to practice as a harm reduction center under the statutory provisions that created those harm reduction centers. And this regulatory proposal is not intended to change that regulatory structure. But if you're not a harm reduction center, then what this provision does is say that you can, if you're an ambulatory care facility or if you're a substance use facility, you can distribute naloxone, testing strips, and other forms of harm reduction strategies, so long as you notice the Department of Health that you're intending to engage in this adjunctive service. So for any of the adjunctive services, you don't need a separate license, but you're required to provide notice to the Department of Health that you're going to provide, you're going to be providing those services. So one of the things that is required is that if you are engaged in a process under harm reduction or any of these adjunctive services that involves the use of medical waste or the creation of medical waste, or that involves infection related problems of infection, that the Department of Health may inspect your facility once you notice them that you're engaged in these harm reduction procedures. So that's something that you have to be aware of. Now, if you're doing something like nutritional counseling, for example, which is one of the adjunctive services, then you're not engaged in the creation of medical waste. You're not engaged in activities that raise infection control concerns, and the department has assured that they will not do an on-site inspection for those services. So both of these and other adjunctive services raise concerns about services that are sometimes address the needs of very vulnerable patients by organizations that frankly have to engage in sometimes relatively informal structures for the provision of these services. And we want to make sure that the regulations, which did go a fair way to make this flexible, is flexible enough. These regulations are flexible enough, or if you think that there could be more that could make the regulations work better, then let us know. Okay, so next slide. So withdrawal management and stabilization has been a sore spot, and I will say that because of who the Commissioner of Health was when these regulations were drafted, Commissioner Dr. Bastian, I have would have sort of sight unseen a sense that she has addressed what has been a terrible sore spot, and induction for people who need MATs and so on. But I want to hear if people think that they can be improved further. There's a requirement for induction that there's oversight by a nurse. And there has to be assessment of vital signs before the patient leaves the facility, if the induction is done in the facility, and that there's a dispensing limit on multiple days supply of opioid of MATs. Now, I'm assuming that refers to methadone and not Suboxone, for example. So there's been a long history of conflict with the department over their imposition of requirements on licensed facilities that are not similarly imposed on the private practice of physicians. And I want to make sure that we hear from people who are providing these kinds of services whether these regulations are appropriate, whether they have squared the circle, whether they have taken care of the barriers that I know that Dr. Bastian experienced when she was in private practice, and that we can't improve on the language here. So we'd love to hear from you on this one. Okay, next slide. Almost done here. So this is one that I have concerns about. Obviously the department is intending by this draft to accommodate the interests and needs of healthcare providers who use alternative sites for care. For example, an FQHC that provides occasional services in a reentry program. And facilities that use mobile vans, organizations that provide services for unhoused people. So they're trying to accommodate the interests of those folks. I want to raise a couple of concerns for regularly scheduled outreach, so that the regulations divide these alternative location regulations into two categories: one regularly scheduled and one intermittent. So if it's regularly scheduled, if a site is regularly scheduled, then there has to be assurance that the physical environment of that alternative site meets the requirements for infection control and safety, and that the schedules are provided to the department. And for intermittent services, that problem could be greater. The problem of providing advance notice to the Department of Health of each service day, the staffing plan and service description, and so on could be problematic depending on when and how those intermittent service requests arise. Now, there's tension here. Of course, the department has every right and obligation to make sure that infection control procedures and appropriate patient protections are recognized here. But again, we ask that you look at these, particularly if you're an FQHC providing services off-site, if you're providing services occasionally in another setting. Now, let me be clear that this is helpful because it obviates the need, which had been asserted by the department under previous regulations, that an FQHC that wanted to provide once a week or once a month services in another setting had to get a separate license for that alternative site. And this is an improvement. Then it doesn't require that. It provides notice, and it provides you have to provide some assurance that the site that you're operating in meets the department standards. But look at them and let us know. Now, mobile units. Mobile units, similar issues, but I want to raise one in particular. Many of you some of you provide services through mobile units for HIV services, for hepatitis C services, for IDU drug user services, and registering the vehicle makes sense, and ensuring that infection control is met. The one that's jumped out at me was documenting routes. Now, as some of you know, when you're trying to provide services for unhoused people, you sometimes don't know where the mobile van is going to go, where the mobile facility is going to go, because you have to figure out where the people you want to serve are tonight or are this week. So I want us to think about that issue, and see if we can suggest maybe some improvements in that regard. Last thing I'll say is there are waiver provisions, and it may be that those waiver provisions will allow for accommodation of the concerns that I've raised. But the waiver provisions are allowable but not guaranteed if you apply for a waiver. So I would like it if people would think about these issues, particularly for occasional out of facility services and for mobile services that address the needs of very vulnerable people. Next slide. Back to Kate.
Thanks, John. So we've discussed a lot of the components of the regulation, and I think the elephant that will remain in the integrated care waiting room is that there will still be components that are not entirely under the leadership of Department of Health. So the Department of Health is still the leading licensing authority with the new rule. However, the rule itself acknowledges that there will be significant continued interagency coordination that's required, particularly because there are many funding and operational rules that still exist under Department of Health, or I'm sorry, Department of Human Services, in relation to the care, billing, funding, and oversight of these different programs. So that includes programs that are governed by the Division of Mental Health and Addiction Services and the Division of Medical Assistance and Health Services, inclusive of Medicaid or NJ Family Care. And so while license will still be centralized and integrated, dual oversight will have to remain in practice for behavioral health and substance use disorder programs that are all operationalized through the Department of Human Services. Providers will need to be attentive and aligned to both sets of expectations in continued practice. I do want to call out specifically, though, however, that the rule does introduce a formalized waiver process. It's within 843 subsection 2.10. So it allows the Commissioner of Department of Health, in consultation with the Commissioner of the Department of Human Services, to waive provisions of the rule, including for pilot programs that may be testing out new models or new integrated models of care, as long as the waiver does not compromise patient safety or public health. So we'd love to get feedback and understanding of this process. I will also say, within both the waiver outline that's there, as well as the forms that are included within the waiver, or I'm sorry, within the proposed rule that would just allow you to apply for an integrated license. We aren't specifically going over those today, but we do note that there are some changes between what's required for applying for the integrated license from the original forms in each of the 3 different licensure types. And there are a number of questions that at first glance we found to be a little bit confusing, and would love for folks to take a look at those going forward and let us know their feedback if they have anything particular to that. So in a moment, I'm going to drop the full proposed rule into the chat so you all can, at your leisure, take a look at it. It looks like we've got at least another 24 hours of rain ahead of us, so you'll have plenty of reading time on your couch. But for now, we're going to take down the slides, and John and I will turn things over to Linda to facilitate conversation. I know there's been a variety of questions and comments put into the chat already, so we can start with those, or folks are welcome to take themselves off mute to ask questions. So Linda, I'll turn it over to you.
Great. Thank you. Thank you so much, Kate and John. And I know you said you're turning it over to me, but don't go anywhere, because I am going to lean on both of you to help answer some of these questions. But as John and Kate both mentioned, we have a wealth of both history and knowledge on this call, and we really want this to be a group discussion where many of you can also help us answer some of your colleagues' questions. I wanted to just clarify a couple things and then jump into your questions. So the Quality Institute does intend to submit comments. I know that the department greatly appreciated when we submitted a letter all together, with which many of you signed on to push these regulations forward. And it was very valuable to them. And I know that they appreciate having consolidated comments, because it enables them to have the sense, at least, that they are being very responsive to the public, and that we have consolidated and put together as many of these questions or comments as possible. And that'll help them reach their goal of adopting the regulations before the end of this administration. So certainly there's no, I mean, it's totally optional to you, but we will give you the opportunity to sign on to our letter. And then, of course, many of you, I know, of course, you're going to be submitting your own as well, but feel free to sign on to ours, and we'll provide it to everybody who participated in this call in advance. We're not going to start doing a lot of editing, so it's just going to be kind of a you want to sign on or you don't kind of thing. But certainly we appreciate you participating today. So to jump into some of the comments, Lee, I see you, and maybe you want to take yourself off mute, because you asked a couple questions that I think are really relevant to everybody, which kind of goes to, if you already have a license and you like the license that you have, can you just stay status quo, or what do you need to do? I'm paraphrasing, but I think that's where Lee was going. Yeah. John or Kate, do you want to take that?
Well, I'll start, and then Kate can correct me. But the way that this regulation is framed, if you have, for example, an ambulatory care license, you can continue under that license. You have to file a notice that you intend to do so within 60 days of the finality of this regulation. And then when your next renewal comes up, if you intend to simply continue in as an ambulatory care facility, you can do so. You will now be regulated under Section 43K, but the standards might be slightly different, but you don't have to expand to other services or do a dramatically different application.
So regardless, just as a point of clarification, so regardless of the license you hold, whether it's ambulatory care, drug, substance use, mental health, you still have to apply, you still have to send a letter of intent 60 days after the letter to say, yes, I'm staying in ambulatory care, or no, I'm going to integrated care.
That's
Is that
right.
correct? Regardless
That's
of
right.
licensing
And
status.
that's right. You will submit that notice and you will receive in return a certificate of a transitional license. So you will continue to have your license. You will staple to it this notice that you have a certificate of transitional licensure, and you continue under your current license as you have. And then when renewal comes around, you will reapply under that standard. Now, I want to be clear that I'm not giving legal advice here. So you want to make sure that you're consulting with counsel about whether there are any changes that you have to anticipate as you want to conform to the new license. But the intention of the department is clearly that you can continue under essentially the procedures that you're operating under now.
So let's say it's time for renewal and we say we don't want to apply for the integrated care license. Can we stay with our ambulatory care license, or are we subject to integrated care regardless?
You will be subject to Section 43K. That will replace the title that you are currently regulated under. The intention of the department was to incorporate into 43K the substantive provisions of your current licensure requirements, so that while it will have a different regulatory designation, the standards were intended to be consistent with your current regulatory oversight. So you should consult counsel before you do this, but the idea is not to require that everybody get a different form of license, but that there be essentially what we think of as a drop-down menu. So if you have an ambulatory care license, you sort of click on the drop-down menu and you comply with that, and it should be essentially consistent with your current license.
Thanks. Okay, I'm going to move on to the next question. Thank you, Lee. I want to move on to the next question that Mary Abrams raised. And Mary, feel free to unmute yourself if you'd like. But basically, some providers of children's mental health outpatient services want to be able to provide therapy to youth in schools versus having the youth come on site. So this is that adjunct mobile type of site issue. It seems from what was discussed today, the provider would have to give advance notice to DOH every time they would have to do that. From my reading of it, and again, John and Kate chime in, if you have a contract with a school and you're going out there once a week, you'd be providing that type of information in advance, but I don't think you'd have to do it prior to every single day. I think it's just really advising the department of that schedule is the way I read it, but that is something we could certainly ask for clarification or a sample forms as to the level of clarity. I don't know.
Hi, Linda. Thank you. No, this case, it's not a contract with the school. It's students that are being served by a particular agency, and some of their locations are like half a mile up the road from a school. Excuse me. And the youth would have to travel on site for their therapy. Under their license, they could not go and meet the student at the school to avoid that. So it's not contract, it would be regular, it would be individualized to students in their area that they would just see, as opposed to those youth having to get there themselves or with their family travel to the facility site.
I I would, if I understand the question correctly, the licensed facility that is now serving patients in its facility, but would rather be able to serve those patients in another setting. Say you get the school to set aside a room, an appropriate room for those services. You Under my reading of the rules proposal, you would not have to notify the Department of Health every time you do that, but rather provide a schedule. So if you want to provide a scheduled series of such service provision once a week for the next 6 months, and you provide the information to the Department of Health that both assures that the site is appropriate, that the qualifications of the person performing the services are consistent with your license on your home facility, then I think that just providing a schedule is what the regulations seem to require.
So you're saying, you said once a week, schedule, does that have to be specific dates and times, or do they allow that flexibility?
I will tell you without giving you legal advice, I will tell you that I understand the regulation to require that you provide a schedule. And I understand that to mean that you tell the department, we will be on this site next Tuesday at 10 o'clock,
Mm.
and then the following week on Wednesday at 11:30, and you update it as necessary. But it's not, we will be at this other site from time to time. I think that they're asking for a schedule. I think they mean a schedule. That's how I read it.
If
And
I could add,
I dropped the particular section of the proposed rules into the chat. So you
Yeah,
can
and we can definitely, I mean, it sounds like, and again, as John said, we don't know what they're looking for, but so we can speculate. And I think that there's enough questions here that we should just ask for a little bit of clarity and some FAQs or things like that. It could be, as John was saying, between the hours of X and Y, or it could be good enough to say once a week, every Wednesday, so we can ask for clarity, but we absolutely don't know sitting here today exactly what they want. So
Thank you.
thank you for yeah.
if I,
Deb, did you want to jump in?
yeah, I want to jump in. So, I think that one of the barriers was being able to bill Medicaid, without doing a spa. So I'm not so sure if putting it in the licensing without them going back to CMS with a spa would be sufficient. That over the years has been the problem. If it met over, so if under existing regulations, there had been, I can picture being at the Department of Health on the committee when we were discussing these, and that came up that,
Yeah,
yeah, as the barrier not being the regulations as much as the billing and what is allowed by federal
right.
Medicaid. So,
Yeah, and then this is just for you raise a good point, and this is just a general comment on this topic as a whole. Today we're discussing the facility regulation.
yeah,
Of course, yes, there's contracting issues, there's billing issues, and this is a facility regulation that does not change
address.
those things. So
Yeah, if I
that
could,
that's a separate issue, of
if I
course.
could just add to that, Deb, I
Yes.
think that you're right, and I think that one of the things that we hear from Medicaid with respect to the questions similar to the one you're asking is this service being provided in a setting that is covered by the Department of Health license? And sometimes the services that you're discussing, when they were off-site, were either in a gray area or simply not covered by the Department of Health license. And Medicaid was quite firm that they would not pay for those services. It would be worth reaching out to Medicaid to pose that question, to say, now that that service will be covered by our license because the adjunctive service or the alternative setting provision in the new license allows us to provide those services under our license, will you now pay for it? And I'm not sure they would need a spot for that. It's just just my thought. They're providing payment for licensed services, so it would be worth reaching out.
Sure, and thank you. I also remember it being a threshold because I clearly remember that discussion of it being because some of our entities, in fact, I think it was Integrity in particular, had an arrangement that so many hours per week, and that was allowed that they could take, clients to a facility for primary care, but it was once it went over that threshold. So that's what I'm just, I guess we have to explore further whether this would like fix that and then just by it being in the regs and take care of that, which I hope it does, but I don't know because I'm remembering
Yeah, I'm
that
hopeful too, but it's
discussion.
certainly important to follow
Yeah.
up.
Okay, thank you.
Thanks, Deb. I don't see any new questions in the chat that we haven't already covered, but I wanted to circle back for a moment to some of the things that John raised that would be helpful for us to get a little bit more feedback on. Some of them are specifically if anyone had any further comments about the wound care service section, maybe from your own direct experience. And I don't see anybody coming off mute for that one. The other one was about the harm reduction question, and if people see any issues with the way that is formulated.
I guess wound care would just be having the staffing that did come up in our addiction practice groups. And actually, I think we had conveyed that at one point, definitely strongly, because of course with uh, xylocaine, there being a lot more wounds that they're suddenly seeing and treating. So it went back to the staffing requirements and having the requisite credentialed staff in. But so I guess I'll make a note for us to look at that more closely to see if there's anything more that we would need to comment. But I'm glad that it made it in because in fact, I saw something, what was it, last week or something? Philadelphia Inquirer, and they had, pretty graphic pictures there. It's, definite need. Yeah. So thank you.
Yeah, particularly in South Jersey, I guess. With the
Yeah.
change in drugs of preference, there's incredible increases in wound care needs, and
Yeah.
just making sure, Deb, that it'd be great to hear from you. It would be if we can be assured that there won't be barriers that will prevent people from going to where the need is to provide wound care. Of course, you have to have proper infection control and proper personnel and so on, but I'd love to hear from you on that.
Okay,
Okay,
thank
yeah,
you.
thank you. Okay, so I do see that some of you have been adding questions to the Google chat here or the Google document. So Pam, if you're on still, did you want to unmute yourself and ask your question, or I can summarize, whichever you prefer?
I'm here. I was just thinking about, with our Healthy Steps programs, we've had a lot of inquiries around outpatient, children's mental health providers employing licensed behavioral health provider to provide clinical services on site in pediatric primary care locations. And we've always been advised that really from a billing perspective, that's not necessarily possible. But I think you sort of answered it with one of the previous questions, but billing is sort of a separate component, but theoretically, the outpatient provider could provide DOH with notice that they have a schedule at the pediatric primary care location to provide mental health services.
That's my hope. Certainly, I think that this seems to be an issue that we'd be better off tracking down before June 20th than not. Um, I guess that my general view is that so long as the Department of Health approves as a licensure matter the provision of those services in that site, then Medicaid ordinarily is willing to pay. There's a lot of qualifiers in that in that sentence, but I think it would be worthwhile trying to pin that down. So I'm hopeful that that this regulation that sort of brings into 2025, the practices that people are following in various settings will allow for Medicaid to rethink what it pays for and what it doesn't. But we're just not sure, but we should track it down.
Appreciate that. Yeah, it just becomes with, having to employ a licensed behavioral health provider in pediatric primary care, if they're not an independently licensed practitioner, supervision becomes an issue.
Yeah.
And if they were employed by an outpatient provider and could have that supervision structure in place there, it would really open up employment possibilities.
Great point.
Yeah, yeah. No, this is this, and along with what Mary and Deb were saying, is good, and certainly aligns with the intent of the regulations and the social impact statement of it. So, or one of the impacts, I forget which one, but anyway, we'll include this and see what they come back with for sure.
And can I just add, Linda, that
Yes.
as this process has gone forward over the last 175 years or however long it has been, the Department of Human Services has been quite engaged, including the present commissioner. So strike while the iron is hot. I think we should try to track down questions like Pam's question and Deb's question and Mary's question now while these regulations are still being formulated.
Yeah.
I think that they're receptive to that. And let's try to figure it out. Let's try to get them on board with this before the Department of Health regulations are done.
Yep, agreed. Michael, I see that you put a comment in the document, which seems to be along the same lines of what we've just been talking about, but did you want to unmute yourself and clarify or expand on that?
Excuse me. No, I think we've talked about it, at length, and it sounds like from what y'all were talking about, we're going to get some additional clarification on that point. But whether it's a school or a federally qualified health center, whether it's mental health or substance use, I think really understanding the standard for providing mobile or community-based services as an extension of an ambulatory license is one of particular interest, and certainly having the details about how that would be performed within the regulation in terms of the schedule notification and so on would be incredibly helpful. And I will just kind of comment, though, I think a lot of what we're talking about here with respect to whether it's adjunctive services or the mobile-based services and community-based services, understanding and working with Medicaid on really understanding how these things can be billed for is essential. And just to kind of add to what Deb was referring to before with respect to staffing, and that's whether we're talking about nurses in a behavioral health facility or clinicians in an ambulatory facility. The staffing is really dependent upon the ability for those professionals to bill for the services provided and rendered. And so I think it would behoove our system and Department of Health and providers to really understand whether or not we will be able to bill for services and given the changes outlined in the integrated license. I think that those two things go hand in hand, because it doesn't seem to me that the intention is to put these regulations out there and then not have them actually be implemented and operationalized by providers. And I think that is a key component to bringing this license to life and really doing what's intended in integrating services.
Okay, no, that's well said. Interesting, because we're commenting on Department of Health's regulations, but as Commissioner Brown mentioned, these were all built in close collaboration with DMOS, and so really what we're asking is for some feedback and engagement with DMOS at some point. I'm not sure where in the process it would be, but at some point to really, as you said, bring these regulations to life or into operation in a meaningful way where people can be reimbursed for or paid for the services that they want to be investing in and then delivering.
Absolutely.
Which I think is what Lee is also saying and was just entered into the document as well. So Lee, I don't know if you want to add in, but I feel like we've captured this pretty well, and this is something that at least 5 of you have mentioned now. So we'll take that as a key point.
So it's not so much about reimbursement as much as it is about meeting standards.
Their standards, DMOS's standards.
Yes.
Okay.
So like New Jersey SAMs, if you're providing substance use, those types of standards that are required under an SUD license.
Okay.
That's really it's not about the reimbursement. It's about
Got it.
oversight and regulations that you're required to now comply with as you go into these separate areas. So yes, ambulatory care, but if we do SUD and mental health, then what regulations are we now subject to comply with? And I'm not familiar with all of DMOS's regulations, but I'm aware of some of them. So that's really the question that's behind that.
John, do you want to jump in on that? Or
Yeah, I'll say two things. One is that as I read these regulations, they are not intended to affect the requirements from DMOS that behavioral health services continue because of the way that governors have shuffled things around. That behavioral health services continue to be subject to licensure regulations from the Department of Health and programmatic regulations from DMOS, and that these regulations, as I read them, do not change that. So to the extent that DMOS's programmatic regulations require the behavioral health providers engage in certain staffing or programmatic steps, I don't think this regulation changes that.
Okay, so as an ambulatory care provider, we would then be subject to DMOS's regulations.
If you are now, you will continue to be.
We are not as an ambulatory care provider.
And are you intending to add services?
Well, that's my question. If we're adding SUD or mental health services, we then are required to comply with DMOS regulations.
If I am now, I would hesitate to say guessing, but I will say that that it is my reading of these regulations that if you are intending to change your license under the integrated license standard 43K to add to your ambulatory care practice a mental health practice, it requires a separate component in your licensure with the Department of Health, then you are also subject to DMOS licensure. If you're doing minor additions under adjunctive regulations, and I think not, but I don't know the answer to that, and that would be a good question for us to ask.
yeah, so thank you, John. So we need to wrap up to keep to our promise of ending at 1:15. But Lee, I appreciate your last comment. And
Linda, if I
you
could
got
just
it.
jump on there for Lee's question and say it's not only DMOS, the provision, you would also have Medicaid regs, and they do not always match. So you would have
Okay.
two sets of regs.
So we'll put, we've got those comments recorded here and in the Google document. And if anyone else would like to add to that, that is a live link. So please continue to add your comments in after this call. Again, we have until June 20th to submit the letter. So we'll be working on it and sending it back to you. And we appreciate everyone's time and attention to this. And thank you for supporting this effort to advance the integrated regs so that they can be adopted this year. And have a great Memorial Day weekend. And thanks again. And thank you in particular to Professor John Jacobi and Kate Shamszad and the team here at the Quality Institute to put this together. So have a wonderful day. Thanks, everyone.